Welcome to Midlife Clarity with Dr. Tracy Page, a podcast for women over 40, navigating hormones, metabolism, strength, and confidence in midlife. Midlife is the moment you start asking bigger questions and expecting better answers. This is where we stop minimizing symptoms, dismissing perimenopause and menopause changes, second-guessing ourselves, and accepting this is just how it is. Instead, we get informed. We get curious. We get clear. Because midlife isn't about hot flashes or hormone shifts. It's about energy, strength, metabolism, relationships, identity, purpose, healthy aging. On this podcast, Dr. Tracy Page blends evidence-based medical insight with honest conversations to help you understand what's happening in your body, support your hormones, strengthen your metabolism, and build lasting confidence in this next chapter. You deserve clarity about your health, and clarity changes everything. Here's Dr. Tracy Page.
Hi, welcome to Midlife Clarity. I'm Dr. Tracy Page, and I'm so glad you're here. I think when you have clarity, everything is easier, at least in my world and in most of my patients' world. And so it's my job to bring that type of insight to you and to help you understand and be clear about what's going on in the medical field, especially in functional medicine. So today, our topic, I've been doing a series on peptides, and we did an overview of peptides, and then I did larzotide. So today, I'm going to talk to you about BPC-157, the body's own repair code. So there is a pentadecapeptide that helps tendons, joints, and gut. And why oral and injection are two very different medicines, but with both amazing results. Now, if you listen to my first podcast on peptides, you'll understand there's a lot of stuff going on in the FDA around this, and we're going to get some really clear answers in July on the 20th, I think it's the 23rd, 24th, I think those 2 days. So BPC-157 is one of the peptides that we were not able to get in compound over the last few years because it was placed on Category 2 list. But the ingredients to make BPC-157 have come off that list, and I am seeing it in licensed compounding pharmacies. So I want to talk to you about it today. It's a very powerful peptide. Okay, so we're going to talk about Lisa. And remember, I don't use real patients' names, but I use the patient cases because they're all relevant to the people who are listening to my podcast. So 52 years old, 3 failed cortisone shots, 2-year tennis elbow. So she's been struggling with tennis elbow, and a chronic gut issue she didn't know was actually even connected. She came in for her elbow. We do see musculoskeletal patients all the time, and we healed her gut. Her elbow healed too because of BPC-157. It doesn't treat injuries, so we're going to talk about that. It restores conditions under which the body heals injuries on its own. And the form you take, it determines which part of the body gets the message first. Okay? So BPC-157 isn't a painkiller. It's not a steroid. It doesn't mask symptoms. It restores the peptides your body already makes, just not enough of it after age 40. It's the same molecule we're reintroducing, and the body recognizes it as its own language, responds the way it was designed to respond by healing what was waiting to be healed. So again, the peptide your body already makes is super important. Okay, so Lisa, she's 52. She walked into my office with a folder. Everyone has a folder or a list full of MRI reports, and she wasn't really happy because she's been told 3 times that nothing more can be done for her. 2 years earlier, she had picked up tennis. She loved it. And I always tell patients, do the thing you love. There's no perfect exercise. It's the one that you love. She played about 3 times a week. She would do doubles with friends. And it was a kind of joy that midlife women have to fight for and protect because so often we give up our hobbies or don't even have hobbies in midlife. And about 6 months in, she developed lateral epicondylitis, which is also called tennis elbow. She did everything right. She rested it. She iced it. She switched her grip. She saw an orthopedist. She did 6 weeks of physical therapy. She got a cortisone injection, and then she got a second one, and then she got a third one. Each cortisone shot worked for about 3 weeks, and that was 3 weeks of bliss. Then the pain would come back, and a little worse than before each time. By the time Lisa came to me, she could not lift a coffee cup with her right hand without wincing. And I've seen this. They can't shake hands, they can't hold items, they can't write. Like, it really is painful. She had stopped playing tennis. She had stopped lifting her grandchildren. She had stopped doing the small daily activities that made her feel like herself. Her orthopedist had told her that the next step was surgery. And I'm not against surgery, so please know that. But what her orthopedist had not asked about was, no one asked about the rest of her body. And that's what medicine is really good at. So really good at compartmentalizing certain areas of the body and becoming experts of them, that we lose the thought that things are interconnected. But in functional medicine, that's what we do. We connect all the pieces. And here's what Lisa told me when I asked. She had also separately been diagnosed with mild ulcerative colitis 10 years ago. It was, quote, managed with medication, but she still had flares 2 or 3 times a year. She had occasional bloating. She had developed a sensitivity to spicy foods. Her last colonoscopy showed mild inflammation in the descending colon. Her gastroenterologist had told her to keep doing what she was doing. And she had 2 separate diagnoses, 2 separate specialists, 2 separate treatment plans, one for the elbow and one for the gut. And yet, the same underlying problem. So this is interesting. Lisa came for me for her elbow, and we started by healing her gut. And here is what nobody had told her. The same molecule the body uses to repair the lining of the intestine is the same molecule that repairs the tendon at the elbow. They're not separate problems. They are the same problem expressing themselves in 2 different rooms of the same house, if you want to think about it that way. The peptide we're about to spend the next 30 minutes talking about is BPC-157. It's the only intervention I know that addresses both at the same time, because it is the body's own repair code. And by 52, Lisa wasn't making enough of it to help her. Okay. Today, we're going to talk about what BPC-157 actually is, the human and the animal data behind it, why it works on so many different issues and tissues, and critically, the difference between taking it orally and injecting it, because there is a difference. Because those are not the same medicine. They go to different places. They do different things. And if you don't know which one you need, you can spend hundreds of dollars on the wrong delivery and conclude that the peptide doesn't work, when in reality, you just sent it to the wrong floor of the building, okay? Or the wrong place in the body. By the end of this episode, you're going to understand exactly how Lisa got both her gut and her elbow back, and why so many midlife patients benefit from this peptide more than almost anything else in our toolkit. Like, this is a great peptide, and when it got taken away, it was pretty sad, but it's coming back. So let me start with the name, because the name actually tells you almost everything you need to know. BPC stands for Body Protection Compound. The 157 refers to its position in a longer protein found naturally in the humic gastric juice, your stomach acid. Your body makes this molecule every day in the protective lining of your stomach. It is the part of the cytoprotective system that keeps your gastrointestinal tract intact under stress, under acid exposure, under inflammation, under all the daily insults the gut absorbs. The synthetic version we use in functional medicine is a 15 amino acid sequence, a peptide that mimics this naturally occurring fragment. This is important. BPC-157 is not foreign to your body. It's not a steroid. It's not a stimulant. It is a molecule your own gastric mucosa produces, just not in the adequate quantity once you cross into, you know what, midlife. The statistics on why you need it. Tendon healing capacity declines roughly 15% per decade after age 30. By the time you are 50, your tendons take nearly twice as long to heal a micro tear as they did at 25. Ligament healing follows a similar trajectory. Slower fibroblast migration, slower collagen deposition, and slower angiogenesis. So, gut mucosal turnover, the rate at which your stomach and intestinal lining regenerates itself, also slows, you know what, with aging. The healthy gut lining replaces itself every 3 to 5 days in a young adult. Isn't that crazy? Every 3 to 5 days, your gut lining replaces itself? By midlife, the turnover slows. Combine that with you know what? Perimenopausal estrogen decline. We just discussed in the last episode how estrogen affects the gut. And you have a gut that is harder to keep sealed. And in the medications most adults are taking, by 50, NSAIDs for joint pain, occasionally antibiotics, and GERD medications, alcohol, and even chronic stress, all of those affect your gut barrier. And it's constantly being insulted while its repair capacity is constantly declining. So we have a gut that has lots of insults on it and a lot of decline in its ability to take care of itself. So Lisa's ulcerative colitis is the visible end of that spectrum. But many of you listening, they have acquired a version of the same biology. You might not have ulcerative colitis, but you could have something that's quieter and very similar. Occasionally, some bloating, low-grade inflammation on labs, like a slight elevation in your CRP, which is C-reactive protein, food sensitivities you didn't know you had, or you never had them 10 years ago, and joints that ache for reasons that your MRI can't explain. Okay? And I don't know about you, but achy joints are a real thing when you get older. Like, I've had them. My husband's had them. Like, you have it. Like, and you don't always know where it comes from. So the mechanism of BPC-157 has several mechanisms that converge on tissue healing. And I want you to know them because they explain everything that follows. Okay? First, it is angiogenic. It promotes the formation of new blood vessels in injured tissue. So damaged tendons, ligaments, and the gut lining are notoriously poor vascularized. So they don't have a good vascular system. They don't get a good blood supply, and you need a blood supply to heal something. So they don't get enough blood supply, which is why they heal so slowly. And BPC-157 changes that. Second, it modulates nitric oxide. Nitric oxide is the molecule that controls blood vessel dilation. It controls blood flow and cellular signaling at sites of injury. BPC-157 helps optimize nitric oxide signaling at the exact tissues that, you know what, need it the most. Third, it enhances growth hormone receptor expression. This is a remarkable mechanism. BPC-157 doesn't just supply growth hormone, it makes your tissues more responsive to growth hormone. So it doesn't supply growth hormone, it makes your tissues more responsive to growth hormone you already have. And I said that twice on purpose. It turns up the receivers, okay? And number 4, it increases fibroblast migration and collagen synthesis. Fibroblasts are the cells that lay down the structural collagen of tendons, ligaments, skin, and gut lining. BPC-157 calls them to the injury site faster and helps them work more efficiently. And number 5, it reduces inflammatory cytokines, the chemical signals that drive chronic inflammation, without suppressing the immune system. And you know what? Steroids, they oppress the immune system. So that's why they work so effectively, because they do not suppress the immune system. Okay, so I like to use analogies to help explain things and concepts. Imagine the blood supply to Lisa's injured elbow tendon as a garden hose with a kink in it. It has several kinks in it. The water pressure at the spigot is fine. The plant is willing to grow, okay? But the kinks are choking off the flow before the water reaches the soil. BPC-157 doesn't add water to the hose, it straightens the kinks. Suddenly, the soil that has been parched for 2 years gets the moisture it has been waiting for, and the plant, otherwise known as the tendon, finally heals because it can. That is what angiogenesis means in a midlife body. Not new construction, but restored circulation. And here's the most remarkable thing about BPC-157, the property that has stunned researchers for over 2 decades. BPC-157 is an arrow that finds its own target. This is crazy, but it's true. It's in animal studies when the molecule is given systemically by injection in the abdomen, by mouth and drinking water, or even topical cream. It preferentially accumulates at sites of injury. You do not have to inject it directly into the wound. The molecule travels to where the body is calling for repair. This is called tissue tropism. And it's why BPC-157 can be effective at treating an elbow tendon when injected into the belly, or healing a damaged gut when injected far from the abdomen. The body recognizes its own language and routes the message accordingly. Now, that being said, I do typically recommend my patients inject close to the injury site, but it is true that you can be effective by injecting in the abdomen if you have a shoulder injury. Now, about the human data, because I want to be honest with you about what we know and, of course, what we don't know. The vast majority of BPC-157 research has been done in animal models, primarily in rats. Those studies are extensive, consistent, and remarkably positive across tendon, ligament, muscle, bone, gut, skin, cornea, and even nerve injuries. The molecule has been studied for over 2 decades. It has reached early phase human trials for inflammatory bowel disease. In one retrospective human series, 7 out of 12 patients with chronic knee pain reported relief lasting more than 6 months after a single intra-articular injection of BPC-157. And I've seen this in my clinic. I have used it under a patient's agreement, and I've seen amazing changes to joints that needed replacement. Is the human data as robust as we'd like? Absolutely not. No, it's not. Is the safety profile across all the studies we have remarkably clean? Yes, and that's important. Are clinicians around the country using it carefully with monitoring, with informed consent, which is what I was talking about, and seeing consistent results in their patients? Absolutely yes. This is the honest landscape. I will not oversell it, but I won't undersell it, or undertell about it, I should say. I don't sell things. This is one of the most studied repair peptides we have, and the gap between what the lab knows and what the FDA has approved is, for now, a gap. Functional medicine is positioned to bridge responsibly. So I have used this peptide in my clinic before it was placed on Category 2, and I will use it now that it's off Category 2. This is the part where you'll determine whether BPC-157 works for you or it doesn't. So I want to lean into the next 6 minutes because this is really important. BPC-157 comes in 2 main forms in clinical practice: oral capsules or liquid, and subcutaneous injections. They're not interchangeable. They are, in many ways, 2 different medicines that share a molecule. Okay? Think of oral BPC-157 as the parking garage. Okay? Here's another analogy. You enter at the ground level, the gut, and you walk every shop on that floor before you ever considering going upstairs. Most of the molecule does its work right there in the gastrointestinal tract, where it originated and where its effect is the most direct. Okay? Some of it makes it to the upper floors of the building, the joints, the tendons, and the ligaments, but you arrive late with less product and the elevator is slow. Now think of your injection as the express elevator. You skip the parking garage entirely. You arrive on the tissue floor, systemic circulation with a full dose intact, ready to be routed by the body to wherever the injury is calling. Same destination is possible from both routes, but one floor gets the most of you and the other floor gets the least. Okay? Because remember, originally you're on the bottom floor, you do all your shopping. By the time you get to the second floor, not as much is available. You can think of it as money, not as much to spend, right? Not as much product if you take it one way in the gut versus if you inject it, you get all of it, it arrives right where it needs to, okay? Oral BPC-157, when and why? Oral BPC-157 is your first choice when the primary problem is gastrointestinal. This includes inflammatory bowel disease, ulcerative colitis, Crohn's, leaky gut that we talked about earlier, gastric ulcers, anti-inflammatory induced gut damage, post-antibiotic dysbiosis, so that's when your gut microbiome is all messed up, and the kind of low-grade gut inflammation that drives so many midlife symptoms. It is also a reasonable first choice when a patient is needle averse, and there are patients out there who do not want to put needles in themselves. When the symptoms are mild to moderate or when you are using it as a maintenance therapy after a course of injection. Okay? The oral form is convenient, less expensive, and patient-friendly. Capsules are typically taken on an empty stomach 2 to 3 times daily for 8 to 12 weeks. Okay? The trade-off is bioavailability. Peptides are fragile molecules. The acid environment of the stomach and the digestive enzymes of the small intestine break down a meaningful percentage of the peptide before it ever reaches the systemic circulation. For a gut-targeted goal, this is actually a feature. It's actually a good thing, right? Because it stays in the gut. It's not a bug. You want the peptide to act locally in the gut, so that's great that it's all taken up there. But for a tendon injury in the elbow, that lower systemic absorption, it does matter and might not help as quickly or as much, okay? Injectable BPC-157, when and why? Injectable BPC-157 is administered subcutaneously, so that means just underneath the skin. A small needle just under the skin, typically in the abdomen, similar to how a diabetic patient injects insulin or how all the semaglutide and tirzepatide injections are occurring, okay? It bypasses the digestive tract entirely. The full dose enters the bloodstream and is distributed systematically, where the molecule's remarkable tissue-seeking property routes it preferentially to the site of injury. This is the form to use for tendon and ligament injuries, joint inflammation, post-surgery surgical recovery, muscle tears, chronic injuries that have not healed with conservative care, and any musculoskeletal complaint that is the primary driver of why you have symptoms or why my patients come to see me. Okay. Injectable BPC-157 is what would have helped Lisa's elbow most directly and is what ultimately added to her protocol. Injection sounds intimidating, I know that, especially to patients who haven't done it before. And all my patients, not all, but a lot of them are like, oh, I can't inject myself. There's no way. It's one of the easiest, though, at-home injections in medicine. The needles are very, very small, typically 31 gauge. Insulin syringes. Most patients describe it as no more uncomfortable than a mosquito bite, if that. Patients self-administer at home once or twice daily, typically for 4 to 8 weeks. And I will tell you, I just tell patients, like if you're doing your abdomen or upper thigh, I just tell them to squeeze your tissue several times because the brain registers touch over pinprick. So you don't even feel the needle go in. If you just squeeze, poop, pop it in, and then keep squeezing, you don't even feel it go in. Okay, for patients with both gut issues and musculoskeletal issues, which is the majority, I would say, of midlife patients that I see, we often combine the two routes. Oral BPC-157 in the morning to act on the gut. Remember, you can take it without food. And then injectable BPC-157 in the evening to dry systemic repair. This is exactly what we did with Lisa. Within 4 weeks, her ulcerative colitis flare, the frequency of it, dropped. Within 8 weeks, her elbow pain was 50% better. And within 12 weeks, she was back on the tennis court. Now, remember, peptides were gone for a while, so I'm talking to you about a case that was a few years ago, okay? So here is a clinical pearl. When you buy BPC-157, where you buy it matters as much as which form you take. I'm going to say this over and over again during the peptide series. The single biggest reason patients try BPC-157 and conclude it doesn't work is that they bought it from a research-grade supplier online, a website that calls it not for human use, and ships from an overseas warehouse with no quality control. The peptide may be half the label dose, it may be contaminated, it may be the wrong molecule entirely. So it's not a licensed compounding pharmacy. It's not a pharmacist working with a physician's prescription. So you're getting a verified product at a verified dose. So we only use licensed compounding pharmacies. And personally, I use pharmacies where I know they have gone through peptide training because it is a different type of field of medicine. And I did a whole year of peptide training before I ever prescribed a peptide. Okay. The molecule is only as good as the chain of custody behind it. And I'm going to say that many, many times. Okay. What BPC-157 actually heals? Let me walk you through the systems where BPC-157 makes the biggest clinical difference because the breadth of the molecule is generally very impressive. So tendons and ligaments. This is where BPC-157 has the deepest preclinical evidence. Animal studies of transected Achilles tendons show consistent acceleration of healing, better collagen organization, faster return of biomechanical strength, and improved function. Medial collateral ligament injuries in rats showed similar improvements across multiple delivery routes. Intraperitoneal injections, oral and drinking water, even topical cream. In a small human series, BPC-157 injected into the knee provided more than 6 months of relief in 7 out of 12 patients with chronic knee pain. For tennis elbow, golfer's elbow, rotator cuff issues, plantar fasciitis, and chronic Achilles tendinopathy, this is one of the most useful molecules in our arsenal. So for all of you weekend warriors, this could be your best friend. Joints. Beyond tendons, BPC-157 reduces inflammatory cytokines within the joint capsule, supports cartilage health, and improves the synovial environment. It does not regrow significant cartilage. And I want to say that. It does not regrow cartilage. Nothing reliably does in adults, so there's no way you can grow it in an adult person. But it can substantially reduce the inflammation that drives osteoarthritis pain and slows the progression of joint deterioration. How does it affect muscle? Number 3, for muscle tears, post-workout recovery, and the slow healing of soft tissue injuries that become more common after 40, BPC-157 accelerates fibroblast migration to the injury site, reduces inflammation, and improves angiogenesis. Athletes, including midlife athletes returning to a sport, are some of the most enthusiastic users for this reason, myself included. Because it's no fun to be sore all the time, and soft tissue injuries happen when we get older. The gut. This is where BPC-157 has both the longest clinical use and the strongest, I would say, mechanistic rationale, because it's exactly the tissue the molecule originated in. It heals gastric ulcers. It improves mucosal integrity. It reduces inflammation and inflammatory bowel disease. It protects against inside-induced gut damage, especially for midlife patients who take ibuprofen regularly because their joints hurt. It pairs synergistically with larazotide. Remember, larazotide closes the door, the tight junctions, and BPC-157 repairs the door frame and the walls. So think of it this way. The body has a finite number of repair workers. They have fibroblasts, they have immune cells, they have signaling molecules, and they get dispatched to wherever the body is calling. When the gut is leaky, the entire crew is stuck patching one site. 24 hours a day, heal the gut, and suddenly the workers are free. They show up at the elbow, at the knee, at the shoulder, at the rotator cuff. This is why patients like Lisa often see musculoskeletal improvements that they weren't expecting once we addressed the gut. The contractor was working 2 job sites the whole time. Free up the first one, and the second one gets all of the attention. Okay, so you get that, right? The gut, if it's not healthy, all your work is going to go there. And remember, systemically, you're not going to get much. But if you fix the gut, then all of the BPC-157 can go out and heal all the problems in the body. Nerves. Animal models suggest that BPC-157 supports recovery from peripheral nerve injuries. For midlife patients with sciatica, post-surgical nerve pain, or peripheral neuropathy, this is an emerging application, and it warrants clinical use, but careful clinical use. And then there's the vascular and cardiac component. Preclinical studies show that BPC-157 supports endothelial function and may protect against cardiovascular insults. This is not yet a primary clinical indication, but it is part of why the safety profile is so favorable. The molecule appears to be supportive across multiple organ systems. Okay, skin is the last one. Wound healing, chronic ulcers, post-surgical incision recovery, and even cosmetic indications. Topical and systemic forms have been studied. So peptides like BPC-157 form part of the mechanism behind why regenerative aesthetics protocols outperform conventional ones. So we like to use it with our regenerative protocols. The same molecule that heals a tendon also heals microneedling-induced microinjury or post-neogen recovery. So it actually can be very helpful in healing and response. Okay, so picture a growth hormone signaling at midlife as like Wi-Fi. It's like a Wi-Fi router. Okay, it has weakening reception. The router still works. Your tendons, joints, and tissues still have receptors that listen for the signal from the router, right? But the connection is faint. And the message keeps timing out, right? And we've all been there with our Wi-Fi, okay? BPC-157 doesn't replace the router. That's not its job. It boosts the signal so the receivers in your distant tissues, they can finally connect, download the repair instructions, and execute them, all right? So it's just like when your computer finally works and it does all the things you want it to. That is one of the elegant secondary mechanisms of this peptide. It makes your existing growth hormone work harder, which is so important, especially as we age, okay? So let me walk you through how I prescribe BPC-157 in clinical practice. Again, this is the segment patients tell me they have never gotten clear information on, so I want to be very specific and also to remember, when I talk about selection, typical dosing, duration, foundations first, all that stuff, remember I'm giving you medical education. I'm not prescribing or telling you what to take or how much to take. I'm not treating you, okay? Treatment only comes when there is a doctor-patient relationship, which is not happening on a podcast, right? Okay, so from form selection, if the primary issue is gut, inflammatory bowel disease, ulcerative colitis, Crohn's, leaky gut, ulcers, gastritis, they're getting sick, they have immune problems, we start with oral capsules, or you can get it in a liquid too. But most of my patients, if not all, take a capsule. If the primary issue is musculoskeletal, like a tendinopathy, a ligament injury, a joint pain, post-surgical recovery, we start with a subcutaneous injection. If the patient has both, which is honestly most midlife patients, unless they've been very diligent about their gut, we use both routes simultaneously, oral in the morning and injection in the evening. Typical dosing, I'm not going to give you specific dosing on a podcast, like I said, because dosing requires clinical context, your weight, your other medications, your specific indication, if you're on other peptides. But the order of magnitude is in the hundreds of micrograms per dose, and it's dosed usually twice daily for a course of about 4 to 12 weeks. This is in milligram range, not gram range for peptides. Higher also is not always better. Targeted is best. Okay. Duration. Most patients run a 4 to 8 week injection course for acute musculoskeletal injuries or an 8 to 12 week oral course for gut healing. After the course is complete, we reevaluate. Some patients cycle on and off. Some patients use a maintenance dose 2 to 3 times per week for long term. We don't generally recommend continuous high doses indefinitely because we want to see the bodies internalize the healing. We want to see actually the result rather than become dependent on an external signaling source, right? So we're healing. We should be healing the body so the body can do what it's supposed to do. So you shouldn't be dependent on your peptides. You can have a maintenance dose of 2 to 3 times a week. But, I always cycle patients off peptides because I was taught to, and because also, too, it gives the body a chance to do what it's supposed to. Okay, foundations first. BPC-157 works dramatically better when the foundations are in place. And again, I sound like a broken record, but I will say this in every podcast. So that means, and you know these, adequate protein, at least 1 gram per pound of ideal body weight, which most midlife women are not eating. Remember I said 60% or less. It means sleep, ideally 7 to 9 hours with a hard wind down at no later than 10 p.m. It means strength training because the peptide signals repair, but the body still needs the mechanical input that tells it where to direct the repair. So the strength training really helps with that. And it means addressing the upstream drivers. So anti-inflammatory overuse, alcohol consumption, chronic stress, all of those are drivers. They're creating the damage that we see in the first place. All right. Synergies. BPC-157 pairs powerfully with several other peptides that we'll be covering in upcoming episodes. Larazotide is one that we already covered. You get the door closed, plus the door frame. The rebuilder is all the gut healing. It's accelerated by BPC-157. With thymosin beta 500, or it's otherwise called TB4, you get a complementary musculoskeletal repair effect, often synergistic for serious injuries. And I use TB 500 many times for post-surgical patients who are training for something like a race and they're training really hard and their volume load is high. So I can't wait to talk to you about that one. With CJC 1295 and ipamorelin, or CJC-IPA is how we call it, you get the master growth hormone signal restored alongside the local repair effect. The right combination really depends on the patient, what they're doing, like I said, their foundations, their clinical history, their workup, okay? Monitoring. BPC-157 has remarkably clean safety profiles across 2 decades of use. So I'm going to say that one more time. BPC-157 has a remarkably clean safety profile across 2 decades of use. Most patients tolerate it without any side effects. Occasionally, reports of mild fatigue, mild headache, or injection site irritation occur, but they're typically self-limited. We do not generally need extensive lab monitoring while you're on BPC-157 during your course of treatment. Unlike with growth hormone secretagogues, where we do monitor IGF-1 carefully. Okay, who should not use it? Because there's always the other side. BPC-157 is contraindicated in active malignancy, and you're going to hear that in every peptide. Peptides don't cause cancer, but if you have an active malignancy or there's a chance that you could have one, then you have to be very careful with peptides because they cause things to grow, okay? Given that any pro-angiogenic molecule could theoretically support tumor vascularization. So remember, it brings blood supply, that vessel, that kinked hose, that's no longer kinked, brings blood supply to the area. So it could support tumor vascularization as well if you had a tumor. We don't have human cancer data to confirm risk, but we do not use it in a patient population who has a malignancy. We are cautious in pregnancy and breastfeeding because we don't have any data. We avoid it in patients with active, untreated infections because the immune modulation could theoretically alter the course. And as always, it should be prescribed by a physician or a provider that has been educated, sourced from a licensed compounding pharmacy, and monitored over the course of treatment based on your history, your physical, your labs, all the data. Okay? Think of BPC-157 kind of like a dispatcher who calls the right repair crew to the right address. The repair crew, which is your fibroblasts, your immune cells, your endothelial cells, your stem cells, they're already on the payroll. They live in your body. They have the tools. They have the know-how. What they have been missing is the dispatcher saying, go to the elbow. Now go to the colon. Now go to the rotator cuff. Like that's what it's missing. And BPC-157 is that dispatcher. It tells the molecules where to go. The crew was always capable. They always had the tools. They always lived in your body. They just needed someone to direct them. Okay, so here's exactly what we did with Lisa, and I want to walk you through it because the sequence matters, and I say that every time. First, comprehensive testing. We ran a complete inflammatory panel, including high-sensitivity CRP, sed rate, ferritin, amongst other things. We looked at her sex hormones. Her estradiol was low. Her progesterone was very low. Her DHEA was at the bottom of the range. We did a comprehensive stool analysis that confirmed dysbiosis with reduced beneficial bacteria. Her IGF-1 was below what I wanted it, and her vitamin D was 28. Second, foundations. Protein at every meal, targeting 100 grams per day, a strict 10 p.m. screen cutoff, 2 strength training sessions per week with a trainer who understood midlife women and how to preserve muscle, vitamin D supplementation, magnesium glycinate at night. We removed alcohol entirely for the first 8 weeks. We replaced her daily anti-inflammatory with curcumin and tart cherry juice, which she had after a meal so it wouldn't raise her blood sugar. Third, the targeted protocol. We started oral BPC-157, 2 capsules twice daily on an empty stomach. Paired that with larazotide before meals, remember 15 minutes before a meal. 2 weeks later, we layered in the subcutaneous BPC-157 injection in the evening, targeted towards systemic repair. I did say earlier BPC-157 could be injected twice a day, but remember we're doing oral in the morning and then injection at night. At week 6, we added topical compounding for direct application near the elbow tendon that she was suffering from, her tendonitis. We supported her hormones with low-dose bioidentical progesterone and a transdermal topical estrogen patch. 12 weeks in, here's where Lisa was. Her ulcerative colitis flares had stopped. Her inflammatory markers had dropped by half. Her elbow pain was approximately 70% improved. She had returned to tennis, modified at first, so she did doubles instead of singles, 2 days a week instead of 3 days a week, taking rest and stretching, and she was back to lifting her grandchildren without wincing and holding a coffee cup. Her high-sensitivity CRP, which had been chronically elevated, was now in the optimal range for the first time, and that optimal range is usually less than 1.0. This is what BPC-157 looks like with the right treatment, with the right protocol, and sequenced in the right order. So what can you do this week, even before you see a physician or a provider who could put you on a peptide? But first, who could do the workup? So eliminate or dramatically reduce any anti-inflammatories like ibuprofen, naproxen, aspirin, all damage the gut lining, and they counteract the very repair process that BPC-157 is designated to support. Okay, so it's designed to support the gut, and those things all break it down, the gut lining. Curcumin, tart cherry juice, omega-3s, and movement are all reasonable starting alternatives for mild musculoskeletal pain, and I'm a huge fan of omegas, 2 to 4 grams a day. Increase protein to at least 30 grams per meal because it does help you heal. Tendons, ligaments, and gut liner are protein built. Without the building blocks, no signaling molecule on Earth can repair them. So this is the important thing that you need to take home. If you're not doing the foundations, you're spending so much money on peptides that aren't going to be able to do their job, okay? Add magnesium glycinate before bed. Magnesium supports muscle recovery. It supports sleep, especially deep sleep, and the nervous system regulation, all of which improve the conditions under which the body heals. If you have a chronic injury that hasn't responded to conservative care, ask your physician about peptide therapy specifically. Many primary care doctors don't know this is an option, so it may take a functional medicine clinician to help you, but you never know. Maybe some of them do. Track one specific marker of your recovery. Could be morning pain on a scale from 1 to 10, range of motion in degrees, or a specific functional task like lifting a coffee mug, so that when you start a peptide protocol, you have an objective baseline to measure whether or not you have improvement. Okay? If you recognize, Lisa, in yourself, if you have an injury that hasn't healed in months or even years, if your gut has been quietly inflamed for longer than you can remember, and if your body has stopped bouncing back from things they used to, and you're having chronic injuries, then you may want to hear something that your body hasn't forgotten how to heal. Your body has run low on the molecule that tells it where to start. Okay? So your body does know how to heal. BPC-157 is the body's own repair code, written into your gastric mucosa for the day you were born, just produced in smaller and smaller quantities as, you know what, we get older. So reintroducing it isn't pharmacology, it's actually what I call restoration. And the form matters. If your story is gut, oral is your starting point. If your story is musculoskeletal with a healthy gut, injection could be your starting point. If your story is both, and most midlife stories are both, the combination outperforms either alone. So, hear me when I say don't order it off a research website. Don't guess at the dosing. Work with a physician or a provider who knows what they're doing. Source it from a licensed compounding pharmacy that has to meet protocols and has regulatory components. And give your body the message it's been waiting to hear. I am so excited about this peptide because so many of my patients have benefited from it in the past. In our next episode, we're going to dive deep into thymosin alpha-1, the peptide that rebuilds the immune system after 40. If BPC-157 is the body's repair code, think about thymosin alpha as the body's defense code. Both decline together, both are restorative together, and by episode 4, I shouldn't say episode 4, I think it's actually, we're way past that. But by the next episode, you're going to have the second pillar of the peptide framework in place. So, like I always say, if today's episode resonated with you or you know someone that would benefit by it, share it with another woman or man in your life who has been told nothing more can be done for their chronic injury, or whose gut has been quietly hurting for years and they're complaining, then they need to know this information. Tell them there's a name for what they need, a peptide behind it, and a path forward. And if you're ready to find out whether BPC-157 belongs in your protocol, well, like I always say, you know where to find us. Thanks for listening. I'm Dr. Tracy Page, and I'll see you next time on Midlife Clarity. When you have clarity, everything is better.
Thanks for joining us today on Midlife Clarity with Dr. Tracy Page. Be sure to subscribe so you don't miss future episodes where we continue to break down the science, the myths, and the mindset shifts around hormones, perimenopause, menopause, metabolism, and the strength for women over 40, so you can feel like yourself again, maybe even better than before. If something in today's conversation resonated with you, share it with a friend who needs to hear it. Midlife health becomes easier when we stop whispering about hormone changes and start having informed, honest conversations. Before we go, a quick reminder. The information shared on this podcast is for educational purposes only and is not intended as medical advice. It does not replace a consultation with your own physician or qualified healthcare provider. Always seek professional medical guidance regarding your personal health concerns. Until next time, stay curious, stay informed, and remember, clarity changes everything.